So I'm happy to be sitting here with Dr. Sophia Miles, adjunct professor at Laurentian University. Also holds academic positions at the University of Ottawa, at the Basque University, and Memorial University of Newfoundland. Sophia is also a research associate at the Canadian Health Workforce Network and focuses on building capacity in northern areas through her research on health, human resources, and primary care. Thanks for joining me, Sophia.
Thanks so much for having me, Stephanie.
Great. We know the issues faced by individuals living in remote and rural communities in Canada. And, it seems like we have a lot of the evidence needed to address, some of these issues. So why have we not been as successful in ensuring that these underserved regions have good access to care?
That's a really great question, and I think it's attributable to several considerations which are interrelated, and I'll briefly touch on a few that come to mind. So first of all, just sort of an overarching consideration is that we've got shortages, maldistribution, and mix of health human resources, and this has typically been characterized by surpluses in southern and urban areas and shortages in northern, rural, and remote. And unfortunately, one of the realities of living in underserviced areas is that there isn't the population density and critical mass to support the business case for investing in infrastructure, such as building hospitals and clinics or purchasing machinery to conduct medical tests, and also schools to train and recruit health workers. So the resources and professional supports just aren't there. Additionally, in addition to limited professional support, personal and social support may be lacking as well. I think we get so focused on health workers and their professional identities that we forget that they're people too, and the evidence indicates quite strongly that personal factors in terms of family or spouse and their educational or extracurricular or work opportunities and work-life balance, as well as proximity to social supports, are among the strongest push and pull factors. So if they're too far away from those, that's something as well. Just thinking about the actual geography, there's land and infrastructural barriers that need to be navigated, and so virtual care isn't necessarily an option to address a particular issue. Patients have to travel long distances to receive care, sometimes at great personal expense and disruption to their personal lives. And similarly, if care isn't available, it may not be comprehensive or continuous with different providers visiting on a rotating schedule. And so it makes it really challenging to develop long-term and trusting therapeutic provider-patient relationships. There's also virtual care. Access to virtual care, particularly in rural and remote communities, requires access and affordability to technology, as well as reliable and affordable broadband and internet access and digital health literacy of service users. And even if care is accessible in person or virtually, it might not be sought due to a perceived lack of accessibility or acceptability rather, or negative experiences when interacting with the system or providers. Two final quick points off the top of my head are thinking about the Canada Health Act. It emphasizes publicly funded hospital and physician services, and in rural and remote communities there are more nurses and other health workers than there are physicians, and so this leads to inconsistency between policy and funding and financing. And finally, we're not optimizing our health workforce. We're not tapping into the full capacity of what our health workforce have to offer. There's been much discussion about expanding the scope of practice of different providers to enable them to work to the top of their licenses and use the full breadth of their knowledge and skills. And while this is slowly happening in some professions, such as nursing and pharmacy, it could be happening more in others, such as midwifery. So those are just a few thoughts off the top of my head.
Wow. Okay. So this is very interesting that you mentioned about virtual care. So we would think nowadays that, the best solution for most of our issues is to, think about technology and how do we integrate technology. And although it's important, as you mentioned, sometimes there may actually not be, certain accessibility to this technology, or there is basically lack of adoption due to lack of perceived usefulness maybe, or how to use the technology. There are a lot of factors, and that's very interesting to learn about. So have there been any policies, initiatives, programs that have shown success in addressing access to certain health services in these underserved regions?
Yes, that's a great question. One of the things that I think is quite clear to us at this point is that we can't spend our way out of this problem. A lot of money is being offered to health workers to incentivize them to set up shop in underserviced areas, even temporarily on a visiting basis. And this is really often a short-term band-aid solution. So a few things that come to mind are upskilling, and in doing so, focusing on retention and training rather than recruitment. So, for example, in Nova Scotia, they're tapping registered nurses to train to become nurse practitioners. And in Nunavut, individuals are actually being selected in some cases in partnership with community for upskilling within different provider groups. Similarly, provide distance education options that encourage local training. Two professions that do this are midwifery and physician assistants, where most training happens in communities through placements and supervision by local practitioners, and a smaller portion of training occurs in a formal classroom setting. But there's actually some unconventional approaches to address access issues that have been successful. And I'm drawing upon the example from the town of Goderich, Ontario, which has a population of approximately 8,500 people. And what they did was they focused their physician recruitment efforts on work-life balance and personal push and pull factors. So community leaders and the physician recruiter actually got together and they arranged small-scale fundraisers to build a community center and other venues for recreational activities to have the same amenities that they could find in cities. So they renovated the library, they built a modern collaborative care clinic, and they also got businesses to band together to build a beach house where physicians and their families could stay when they visited their prospective new home. The most interesting and probably unconventional part of this, though, was they went so far as to find out what each prospective recruit needed and tailor their recruitment strategy to the individual. So if one spouse needed a job, they actually made efforts to secure work for them. They even provided babysitters and played matchmaker. And what I mean by that is they introduced two physicians to each other who actually got married. This might be, yeah. So this, I admit, this might be an outlier and an unrealistic blueprint for other underserviced areas to follow. But the take-home message of this point is that you need to potentially focus on recruiting the person rather than the professional, and community buy-in is needed to make these kinds of investments.
That is very refreshing to hear. I think, what this really focuses on is the people, because at the end of the day, it really is people who are the foundation of the healthcare system and that really are the ones providing value. We often forget that, sometimes it is quality of life. It is looking at unconventional solutions. And, it's very interesting to hear that has been successful. And I know it obviously makes sense. Yes. So what do you think are some of those key enablers to support and improving care in underserved regions? So is there anything that really needs to be thought of systematically as a key enabler in improving care for people in underserved regions?
Oh, great question. There are some things that come to mind. First, I would say is that media and political discourse has focused on doctor shortages, as was the example that I just gave about Goderich in Ontario. And they're talking about investments in training spots and expansions, or creations of new medical schools throughout the country. And this is great, but the conversation has to extend beyond doctors. We're operating within a largely physician-centric model, and this doesn't make sense in areas where there are no doctors, and there are areas with no doctors. And so we need to be focusing on which providers are where, and we need to then plan, fund, finance, and take policy action based on that. Otherwise, it's like trying to fit a square peg into a round hole. Another thing is that we need to think about is our informal workforce. Supporting caregivers who fill significant system gaps are vital members of and of great support to the health workforce. Unpaid caregivers provide different types of vital care, so whether it's personal, physical, social, and financial, and provide approximately 75% of care services in the home. And it's been estimated that this labor represents between $24 and $31 billion in unpaid work each year. Another thing, we touched on a little bit earlier, is going into communities and identifying prospective and future providers early, and providing exposure to specific communities and professions or areas of care, and training pathways. So a few quick examples with that is that, like, evidence does strongly indicate that being from an area or exposure to it during training increases the chances of trainees either staying or being recruited to practice in those communities, particularly if they're not from there, but if they do establish personal or professional connections and have a sense of what it's like to practice and live there. There are actually calls within the nursing profession to better prepare RNs to practice in primary contexts, as this is actually not a specific concentration in their pre-licensure training, and such training and exposure can let nurses know about primary care nursing as a career option. We often take for granted that just because they work in primary care settings, they're trained in it, and that's not necessarily the case until after they start practicing independently. And a specific training pathway example is the Rural Generalist Pathway established at the Northern Ontario School of Medicine University in 2021, and it prepares future physicians to provide broad scope medical care in rural contexts. We also touched on this earlier in terms of optimizing our health workforce through policy actions such as legislation and regulation to enable our workforce to safely and competently provide fuller scope care to tap into that capacity. So I would echo that as well, because several provider groups know and have been trained to do so much more than they're currently allowed to do generally, as well as in specific settings if privileging is an issue or if legislation requires it. A couple of final thoughts I would say is that representativeness and intercultural communication within the health workforce. Our society is so multicultural, and while this is the case in metropolitan centers, cultural and linguistic diversity is also important to consider in underserved areas. Especially as Canada and health professions increasingly integrates internationally trained health workers in the healthcare system to provide culturally competent and safe care. And so this is really important when interacting with newcomers to Canada as patients and providers, and culturally and linguistically diverse communities or groups who have been subject to social exclusion, such as Francophones and Indigenous peoples. And finally, needing to take care of our health workforce. As you said, we forget that sometimes they're people too. And I mean, our health workforce has been at a breaking point for a while, and it was COVID that really broke the straw, was the straw that broke the camel's back. And so, we've been hearing a lot in the media about people either leaving professions early due to retirement, among other reasons, or staying in their professions but leaving the public system. And they're burnt out, and they've just endured unsustainable workloads due to staffing issues, shortages, and other issues. And so while this is happening everywhere, this is particularly the case in underserviced areas. And so we really need to take care of them for a couple of reasons. First, a content, fulfilled, and healthy workforce, supports the delivery of high quality care, which can translate into good patient health and system outcomes. And I think there's also a moral imperative to take care of those who care for us. So, health workers, like other workers, are patients too, and they're deserving of care and concern for their well-being.
Absolutely. Yes. And I think you brought up a very good point related to how training is actually done and whether health professions are actually embedded in certain underserved regions and how that will impact their decision of where they want to practice. And you touch on a very important point related to how can we make sure health professions are working to their maximum scope of practice. And I think sometimes that's difficult if health professions don't know each other's roles and responsibilities. So, and I don't know if what your thoughts are on this, but I think as well, actually learning what other health professionals do and what their scope of practice is important to know when to refer, when someone else can do that specific, job, so that I maybe can focus on other things that are in my scope of practice, but not in theirs. So, and that reminds me actually of a program at the University of Ottawa that focuses on teaching health professionals and graduate students about different health professionals so they can better learn together.